Good afternoon. Now, this Friday afternoon, we're having a dialogue on the access to sexual reproductive health and rights for women living with disability in Uganda. Previous discussions in the media and even in other parts of other areas, forums, the thing that has been highlighted is that gaps when it comes to access of sexual reproductive for the youth. For a particular group of people, that is people living with disabilities, on a day-to-day basis, there are challenges. But this afternoon, as I had mentioned earlier, we are going to turn our attention to the challenges that could be economic, societal challenges, even if it's just health, in terms of what they can access and what they cannot when it comes to SRHR services. Now, we do have from the International Community of Women Living with HIV and AIDS in Eastern Africa, with funding from the Open Society Institute in Eastern Africa, they undertook a study on violations of sexual reproductive health and rights of women and girls with disability within the clinical and community settings. The evidence there suggests that more PWDs suffer abuse with persons without disability, and persons with disability suffer multiple vulnerabilities associated with this gender as well as associated with their disabilities. So as we get into that conversation, joining me to have it, we do have Miss Dorothy Namutamba, who is who is the Director of Programs and Advocacy at ICWEA. Good afternoon and welcome.
Good afternoon.
And next to her, we have Joy Nakesa, who is the Programs Officer at SRHR at the National Union of Women with Disability in Uganda. Welcome, Joy.
Thank you. Good afternoon.
We'll start off the conversation with you, Dorothy, when we talk about the study that was undertaken by ICWEA. What were the findings? What is this evidence that we're talking about? How dire is the situation? Okay.
Thank you very much once again, and thank you for hosting us on this show. So ICW, the International Community of Women Living with HIV Eastern Africa, we carried out a study in 3 districts of Uganda that included Gulu, Mbale, and also Masaka. And we were focusing on access to the sexual reproductive health and rights services for women with disability in Uganda. And we wanted to find out what is it, what, for example, are the for the start, the policy framework that exists that protects and supports women with disability to access even the sexual reproductive health services. And secondly, we wanted to find out the real experiences of the women as they do access the services at the health facilities. And what is it at the health facilities, what is available at the health facilities when they do access the different services that are available for them. And we took this study in these 3 districts. We could have done a national study, but really because we thought that, because of the limitation of resources, but also we knew that Gulu would represent our northern region. Masaka, we felt it would represent more of the central region. And then when we took the Mbale, we knew it would represent, it would be a representative of the eastern region. And much as we cannot generalize it to the general country, we're saying that the evidence that we got from all this, the study, it is really, it shows what happens in the day-to-day life of a woman with disability as she tries to access the sexual reproductive health services at the health facilities, but also what kind of life she leads in the community.
Because eventually it will trickle into the way she can be able to access these services eventually.
Yes, yes.
Who will be able to help and who won't. So delving into, should we start with the life of the woman? Yes. What are the challenges there as she accesses these services? Okay, so if I could start, I would love to start from the community, this time, because definitely the woman or the girl who is disabled, and even also maybe to point out right from the start is that we dwelt more on the woman who is on specific disabilities. One was physical disability, second was the visual, and then the hearing impairment, that person who is not able to talk, but also who is not able to speak, to hear. Those are the 3 disabilities that we dwelt on.
and not underscoring the importance of the other disabilities that exist, because there are really a wide range of disabilities that do exist. To mention like the mental disability, albinism, there are many, but we brought on the 3 specifically also because even in our statistics we realize that these are the kind of disabilities that are even on the higher side, much even higher in women and girls than even the men. So those are the 3 disabilities that we dwelt on. And from the community, our study results really indicated that yes, the girls and the women do get support right from their families. As they grow up. Their families tend to support them. Some families, I want to say some families, but not entirely all, they support them as they grow up. And I said some because there are some of those families that do reject girls with disability, women or children with disability, that even when she is counting the number of children that she has, she'll say, I have 5 children and 1 who is disabled. So the 6th one, it looks like he's not even a child, but rather someone who is regarded as another person within the family. But those families that have supported the girls and women, they have been able to lead them, to escort them to health facilities whenever possible. And that, but even when they are leading them to the health facilities or to access other services, one of the key findings that we found was that there's already a feeling of families feeling like you are a burden. You are a burden to the family. So when you make your sexual reproductive health choice or decision to even become pregnant, then you are adding another burden to that family, which is kind of, so there's already that attitude that, so why are you getting pregnant? There's also an expectation that you should not be sexually active, even from your own family. As a woman with disability, as a young girl with disability, that you should not be sexually active. And yet we know disability will not rob you from your other desires as a person. But that is also a feeling that our families also feel for women with disability. Our findings also indicated that as they go to the health facilities, we even find the families negotiating with the health workers to ensure that if their person is pregnant and maybe she has delivered, put them on long-term family methods, that they have even signed somewhere that probably this person should have a tubal ligation, because we don't want to have more burden of the children that she's going to bear. And the other experiences that we got is that the women and the young women with disability in the community, they experience issues of violence much more than even the girls who are not disabled. They experience assault, sexual assault, rape, defilement. There is even a saying that probably there a myth, and I would call it a myth, that women with disability are even more fertile than those that are not disabled. But much as we do not expect them to be sexually active, there's a myth that we found in one of the districts that they are supposed to be even more fertile, more, yeah.
Which district was this, of the 3?
Of the 3, we found that in Gulu. Yeah, so that in itself points to the fact that, yes, they face many of these different violations, like the rape, the sexual assault, that even when it comes to reporting, imagine if the person is not able to speak. How is she going to communicate that I was assaulted, I was raped at the place when she is able to maybe even taken to the health facility? How did it happen? Yeah? So that in itself is a challenge. And back again in the community, even when the the young women and the women with disability choose that they need also to get to have families of their own. One of the key findings was that they do have, negatively they have husbands, yeah, but the husbands that they have only can identify with them at night. But during daytime, I do not have a husband. Somehow he may surface in the night, And that in itself becomes kind of a challenge, where at the health facility where we go, most times we are asked to bring our spouses when you're going for antenatal services. So I've talked a lot about the community, but there is a lot of discrimination, sexual assault, negative attitudes towards people, women and young women with disability, especially when they make those sexual reproductive health decisions around their lives.
Well, as we get into those decisions, which will take us to the clinical setting of things, just to bring in Joy, you've heard what Dorothy has had to say. And you on a day-to-day basis, you interact with these women who live with disabilities. How true, just give us paint a picture for us, from what Dorothy is mentioning. How is it like for these women?
Thank you. I would say that everything is true. As women with disabilities accessing health services, it is a big challenge. Challenging even from the community, the family where she comes from, and up to the health facility. You'd find that once she conceives, that is a problem. Sometimes men run away from them, those who have pregnanted them. Then when time comes to go to a health center to access antenatal services, you find that the health workers, the attitude is very negative towards them. First of all, they will ask you, who is this man who pregnanted you, who did not have sympathy? You are a disabled woman, now you are pregnant. And so it happens when you are crawling on the ground. It takes long to be examined. Then even the fellow women who are pregnant, who have come for antenatal, they also look at you as someone who does not matter. And at the end of it, you find that the morale is deteriorated. So at the end of it, you find that maybe this woman would not opt to come back again to the health facility. Then when you look at the facility, the equipments within the health center, you find that, for example, the beds, the examination beds are high, and this woman cannot climb the bed. And then they will say, you climb the bed and I examine you. Because you can't manage to climb, she will say, why is it that you manage the other one? Because you were pregnanted. So it becomes a curse towards you. So at the end of it, you find that they refuse going back. Then there is this tendency when you go for antenatal, when you look at the situation we are in today of HIV/AIDS, they say, go together and not together. So by the time you are pregnant, but the one who pregnanted you does not want to associate with you. So they are saying, you come with your partner. Where do you get the partner? The one you can go with is a guardian or your mother. Yet they want to test both of you. So on that side, it becomes also a challenge. Then you look at issues, there is what they call mother kit. You need to go, you take to the nurse to check whether you have some, is it scissors, razor blades and other things. Those kits you go with as a mother. You need to go whenever you go for antenatal, you go with this kit so that they check and see how prepared are you for the baby. So the situation women with disabilities go through in the villages, it is not good. And then sometimes men who pregnant women with disabilities would like to associate with them. But because the attitude in the community, you find out it is also alarming. They would say, who pregnanted her? Somebody's husband. Now for you don't have that energy to fight with the woman. So you have to hide yourself. And the man also would say, don't mention my name anywhere. So you remain like that until you deliver. So it is sometimes you find that, especially when you go for cesarean section, it becomes worse because the health workers, they want a lot of money for cesarean section. So you find this woman is suffering in the hospital. You look, some people look for leaders to support, to pay the hospital bills. So it becomes alarming, and as she mentioned, you become a burden to the caregivers. That's why you find that sometimes the first pregnancy, if you deliver, they would negotiate with the health workers. You sterilize her, we no longer want her to continue producing from here, because now who will be caring for her children without the father? Yes.
Yeah. Well, when you mention all of this, it's not something very easy for a person who's living with disabilities. It seems quite heavy. In the house, you're considered a burden in one way or another. You step out, you are considered to be, you're just simply alienated and pushed to the side. No one wants to associate themselves with you. What kind of impact does this have on a lady who is with disabilities? Joy, you interact with these women. What is it like for them on an emotional level, mentally?
Sometimes, like our organization, we normally carry out counseling sessions for them, at least to adopt, to feel those challenges, but find a way how to cope up with them, because it is difficult sometimes when the family members have neglected these women. So as an organization, we come in, we counsel them, and sometimes we look for some support to support them. How can they care for their children? And we can also link them to other organizations. We are happy today that we have International Community for Women. So those organizations that come, we link them to them so that they can also support in where necessary.
Well, with that help, we do definitely appreciate it. Now, Dorothy, we go to the clinical bit, because what the two of you are also highlighting is, yes, there is also this mentality that, you know what, if I'm a parent, I'm going to go and say, I don't want my child who has a disability to bring me another child, so hence let's sterilize. That alone, one, your right to say, I can have my next child has been taken away from you. Your future is in someone else's hands. Yes, let's talk about the clinical setting. Who then protects this person?
Okay, so thank you very much once again, and probably I could have forgotten something in the community that I want to go back to, and the fact that sometimes even the men, the husbands, the spouses could have wanted to identify with the lady or the young woman or the woman whom she has identified as her partner for life. But what happens is that the negative attitude does not only stop at the community level, but even the other side, the side of the man, and when you eventually, because of course you want to show your relatives that this is my partner, this is my wife, we heard and we discovered that the women were like, you know, it starts from the spouse's side. That of all the women that you went to look for, was this the best that you could have identified, really? Yeah, so that negativity comes in, and it comes right within into your ears. So that rejection is outright. So even within this relationship, your husband has been told off that you go and look for someone who is able-bodied and whom we can communicate with or who can see. All that comes into your mind as a woman. But going now to who protects this young woman or the woman with disability, I would say that in our country, good enough, our country has ratified to different international international documents that do protect the life, or rather the rights of the woman with disability. And we also have the Disability Act 2006 that speaks to issues of accessibility, issues of stigma and discrimination. We have our constitution as a country, and that really clearly says that we should not be stigmatizing other people, and also talks about people with disability as our core area to be focused on. But unfortunately, we realize that even when we look at some of these documents that we have, they do not explicitly talk about the sexual reproductive health and rights of women with disability. We have in our country the sexual reproductive health policy, and we are developing a framework. But I would say that that in itself also, if it goes down to the vulnerable women, we are not seeing it explicitly talking about the needs and the priorities of women with disabilities. So the protection starts right from the documents and the policies and the guidelines that we have, that they are not explicit enough to address the needs and priorities of women with disability. And therefore, where do we run to? We have, of course, our Ministry of Gender, and that houses the Department of Disability in itself, and it has really, I think, tried in itself. But coming down to what does it happen, what happens right down at the health facility. In our study, one of the things that we found was that coming to the health facility, I would realize that we have completely left out women with disability, and in terms of programming.
How so?
Especially around the sexual reproductive health and rights. That, yes, Joy has talked about issues of the beds. So if I've come for the sexual reproductive health services, and that this might include antenatal services, may not even be limited to only antenatal services, but also other services. I'm a woman who has come for, say, I am feeling itchy, I don't know how to start it, I don't know how to communicate this, but I'm here and I've come to the health facility. And I interface with a health worker who is not able to communicate with me.
There's already a barrier.
Yeah, already. So we rely on our relatives who come and escort us. If I'm not escorted, then I'm not able to communicate with that health worker. That in our country right now, and in our study, we found that the health workers have not been, I mean, even in their training, very few have been able to even interpret the sign language. I mean, to go through the sign language training. And those that have even been trained could have been done by voluntary organizations that have done that, that when a person comes in, she's communicating, or probably you as a health worker, you're giving a health talk, you're telling the women who are available, this is how you should behave, this is how you should access services, and you're showing, say, you're even demonstrating something, but you are not cognizant that there's a woman who is blind, who is not able to see, who is not able to hear, and there's nobody translating that to this person. So deliberately, we need to see that there is that communication which is not even, the communication is addressed. Otherwise, that is why I'm saying that we've deliberately, there is no way we have involved them in that, in terms of our programming. And when it comes to services, I would say that much as when we look at the sexual reproductive health services from the human rights perspective, that they should be accessible to all, irrespective of who you are, and we should not be stigmatized, or we should be able to make those decisions around our health. And what Joy said was true, was that yes, we found that some of the women whom we interfaced with, they said for them, all of them, because the focus group discussions we had, they all shared the negative circumstance that they went through as they interfaced with the sexual reproductive health services. That those beds that are there, even in all our health facilities, they have either been donated by another organization. We have not deliberately put in some of those adjustable beds for women to climb up, to be examined, and we task them that, yes, probably you should be, since you climbed the bed when you're having sex, then you should also climb this bed when you're being examined. Yeah, and that already sinks into the lady whom you are addressing, that surely you have this negative attitude about it, and of course it is obvious. But in addition to that, even just the structure, the structural outlook of the building and how they accessibility. I know there are some health facilities that have put in ramps for people with disability to climb up and go down. But because the non-involvement at that stage, even during the building, and maybe even trying out once, that probably if someone came in with a wheelchair, she could be able to go up. You find they are either too steep, or they are not even, they cannot be accessed. They are either too steep or they are not there. So that in itself tells you the story that accessibility into the health facilities is also a very, very big challenge. So when we get to the health facilities themselves, that the health workers are not trained to see how their maybe even around the sign languages. They feel like they also want to help, but probably there are no proper guidelines that are in place around the sexual reproductive health, that when I have a disability, I'm not able to communicate, and if I interface with this person as a health worker, where do I start? How should I handle? There are no guidelines within our countries that guide even the health workers, or those policies that guide the health workers who interface on a day-to-day basis with the women with disability who come to access these services. That is, I would say that, and that sympathy, I would think, I know that it again now turns into issues of things like, now I'm trying to help you. Yeah, you should not have more children. There's that feeling that you should not have more children from the health facilities because you're already a burden. That is why they rush you to get into sterilization or cutting of your tubes, or being given the long-term family planning method because they think you're already a burden. The women whom we interface with said that, yes, you're asked embarrassing questions right from the start. We had a story of a young woman who went and she was really disabled, but she was pregnant. And right at the entrance, of course, the attitude towards her from the other women who had come for antenatal was the visual one was enough. But even as the health worker interfaced with her, she, in front of everybody, started asking her questions. So what happened? Who raped you? Were you raped? Were you, who made you pregnant? Who is this man who is not, and just like Joy said, who was not kind? And of course, it's not always that there's a rape. Probably it is a husband, a spouse whom you have had consent and you have agreed. But there's already that attitude, and you do not, in front of other people, you are embarrassed even to open up to even answer any of those questions. So I think that starts it all, that stigmatizations come from the start, that yes, the communication is not there, but also when you get to accessing these services, you get these negative attitudes that someone makes for you a quick decision that probably now you are not going to be able to push this baby because you're disabled. I think we should rush her very fast to the theater and have a C-section because it is going to be a very hard labor for this person. And for cases of women who are not able to speak and who are not able to hear, then also that becomes a challenge. Because in Mbale, one of the things that we realized and we saw, and we heard from one of our respondents was that she had already lost 2 children because she could not communicate during the labor, that time of labor. That at that point in time when she's supposed to be pushing, she's not able to tell the health worker that I'm feeling labor, this is how it is coming, and this is the time that I should be able to push. And also the health worker is not able to communicate. So she had already lost 2 children. One, she had to push when the health worker said, no, I think you are not yet ready, move. And you know how that happens in the general hospitals, that you move her to the side. It is not until she had to move to Kampala that she was able to have a live birth. So those are just some of the challenges, but you realize that they start right from the family, and then by the time they get to the health facility, we are seeing a lot of stigma and discrimination around the lives of women and young women with disability on their sexual reproductive health decisions.
All that you mentioned, Dorothy, is quite unfortunate. The stories that you share from these different areas, because whether you're disabled, whether you are able-bodied, having a child and having life is something that should come easy. Joy, when Dorothy mentioned that it starts from the family, do you have conversations with these families? How has it changed over the years? Do you see that maybe the community is more responsive, more accepting of people with disabilities, or does it continue to just dwindle? Their thoughts?
Okay, if I compare previously and now, there are some changes which are happening. For example, as in Wadu, in the districts where we have implemented SRH, we organize trainings for caregivers, the spouses, caregivers, and the parents. And they come and we sensitize them on how they can support women with disabilities and even younger girls. And this at least some extent is reducing. When somebody has been trained, can change. You know, it takes long to change the mindset of a person, because their perception has been that when you say a woman with disabilities, she can't do anything, she can't deliver, she can't be a wife. So we are trying to sensitize them so that they change from that perspective, so that women with disabilities are able accepted in the community. They are married, no complaint even if she's married to somebody's son. And then the parents would take her as their daughter in that family. So as Nwadu, we are doing that.
And how is the attitude from the people that you speak to, these families that you speak to? What is it like the very first time you interact with them and give them this mindset that, you know what, someone who's disabled, it's not inability, they're able to do a number of things?
At the very time, it was negative, but now it is positive because they have changed from their mindset, because they were thinking maybe these women, they would be useless in the future. But when we do that, there are those model women with disabilities in the community within their local setting. So we normally give them as an example. But with time, they are changing. And even when there are violations of SRH, these parents, they come out open and report. They go to LCs, and as an organization, we have also trained paralegals and local advocates who oversee the violations, and they can help these women with disabilities to report the violations to police, to LCs, so that even the LCs, they were trained, and now also they support. So from where they are, they can call a local advocate, even in the family, seeking for support. Can we take this one to child and family police section to support when they have been raped, those ones who have been defiled? The challenge we have been having before, girls and women with disabilities especially, they are being left at home to be the security guards. So sometimes with these other disabilities, for example, somebody who has a mental health problem, those ones who are epileptic, those ones with intellectual disabilities. So you find that the caretakers, they leave them at home to guide the home. So not knowing that they are creating chances for these men to come, because normally these men who violate the rights of these girls, most of them are relatives. They are friends of the family. So they come there, they ask maybe the parents, what time, when you leave, you go to the garden, what time do you spend there? So with that time lag, this man can come, and when the girl is used to this man, she doesn't know what he's going to do. In a long run, you find that this girl maybe is being pregnant by the very man, but who tells her not to mention his name. So sometimes these relatives are the most violators for these girls.
Well, as we talk about the access to SRHR in terms of when you mentioned the clinical bit and also just the community, things like the violations, a number of times what has been highlighted is the poor dissemination of information of what is wrong, what is right. A number of times you can tell a child perhaps who can hear, who can speak, who's able to move, that if they do this to you, that is wrong. When you mention this joy of the fact that you're leaving this girl at home, leaving her prone to anyone coming in and doing anything to her, but she doesn't know, is it wrong for this uncle to touch me like that? Because they haven't really had these conversations. So taking it to just access to information, and also taking it to the clinical bit where she has a right. She should know she has a right to say, I want to have this number of children, and it is okay. Because of course the health worker might say, and these are just a few things that have been shared, is that they can pass on their disability to the next child that they could have. So where do we say that they stand in terms of information being given to them, and how clear is it? Start with you, Dorothy, and we'll come to you, Joy.
Yeah. Thank you. And I think that's in itself a big challenge, like Joy has said, that sometimes we leave these children behind even as young, that even when you deliver a child who is disabled, at that point, some parents decide that probably I'm wasting my money. Why should she go to school? Yeah, how will she move? Who will be taking her on a daily basis? And there's a bit of, for some families, we find some children who have already been rejected at that early age. So they grow up. Some do not even go. If they go to school, they would end somewhere, and they do not go higher than what where possibly even their brains could, their capacities could have taken them. So access to information is very, very, very critical. That yes, they may even be, they turn into adolescents, and they're going through changes within their bodies, but no one, probably even their mothers, might have chance to explain to them that when this happens, this is what you should do, because she's a normal child and she'll be going through all these other changes. But this information that you should be able to protect yourself. When this man touches you here, please don't allow. Imagine if a young girl is blind and may not even be able to see the person who is doing this. Sometimes, of course, may recognize the voice. But if a person has an intention to harm, to do a sexual assault to this child, probably they may intentionally even change the voice and may not be the person whom you have recognized before. So access to information is limited. That right from the start, as we choose not to even push our children who are disabled further in education, where they could have got some of this other interaction and more information around their own sexuality, then it even becomes even harder at home. Who speaks to some of these children who stay at home? Joy has said that we leave them as guards in the family. If she's epileptic, let her stay at home, yeah? And who takes advantage of that? Who introduces her into her own sexuality? So most times the mothers try, I would say, but they would not go that in depth to know that probably this is a stage. And so by the time even the girl is getting pregnant or she's been pregnanted, it is such a shock to the whole family, and they're trying to find out who did it. Who did it? Probably she didn't even see the person. She didn't hear. Probably she could have identified the person, but access to information is really been limited. And I want to thank Noodu if they are speaking to the caretakers and ensuring that probably this can move from neglect, and I would say neglect because families, we do sometimes put aside these children and we are not able to help them get all this information. But if caretakers take the responsibility that this is information that we need to pass on to children that at such an early age, and we should not neglect them and not even help them go through the formal education. Yeah, so it is still very, very limited from my perspective.
And to you, Joy, access to information?
It is true, I concur with Dorothy. Access to information is very limited to girls and women with disabilities. Because at family level, when girls are growing up, we have the aunts. Those days, they used to be there. But now they look at a girl with disability. Now I sensitize, I tell her over what? Because I don't think she will become a woman, she will get married. So how do they get information, girls and women with disabilities? Sometimes from others, friends. If you happen to be at school, there is a senior woman teacher you can get. But in a situation where this child has not been taken to school, it becomes a problem. That's why you find that there are many cases and violations. Because if you don't know that at a certain age, your body will start changing. So you find the girl is growing up. That is why sometimes you find even these girls with mental disability or mental health, you find that she's moving half naked and the parent does not bother because she has not taken that responsibility as a parent to sensitize her, to dress her properly. Although she has that disability, that is a human being. But for us, as in Wadu, we have been sensitizing the parents. We say that it is a violation and you will be apprehended one time because you are exposing. The more you expose her half naked, you are exposing her to those men, to the perpetrators, to come and do something when she's not aware. And then our sisters, like the deaf, at home when they are growing up, there is no interpreters. And it happens so when this girl goes to school and learns sign language, again she's in a different world. Because when she comes back at home, the parent knows to use gestures. Now she has changed to a different language. So you find that access to information is very limited. But now, like at health centers, they carry out what they call outreaches. But you look at the mobility of women with disabilities. They can put in the next trading center. You are crawling, you don't have a wheelchair, then how will you walk? Even if you are using crutches like me, you can't go there to the outreach and get the sensitization, what the health centers have come to sensitize the communities. So you find that we are left behind. I can give a live example. For me, when it came to periods, I was in P6. But I was not sensitized. I didn't know. I just saw blood coming out. I started crying. I said, what is this? Now I'm seeing blood. I didn't know anything. So I was left out. Till the senior woman teacher picked me and took me to her office and sensitized me, do this, get a cross, do this. So you find that as a woman with disability or a girl with disability growing up, there are things which you miss out. Then in the future, when you happen to become useful, I think the parents will also regret, I wish I knew I did this to her. She would be like this. So those are the challenges women with disabilities and girls go through.
Well, as we mentioned the challenges, it's also best to mention solutions going forward, recommendations. Where should we now change? Where should the focus be? Because when you mention one, just access to that hospital bed, access to enter that hospital, just to get that service you need, the communication there, it's lacking. The bed is not a fit for the person with woman with disabilities. Even the law, the policies. So Dorothy, I'll start with you. Where do we need to see a change when it comes to community before we can go to the clinical bit?
Okay, so the community, the change, I think, I feel Joy has touched a bit on the community. It starts from our attitude and our perception of women and young women with disability. We should see them as whole people, as people who also have their own rights, and that they have also their right to make their sexual reproductive health decisions. And that they have the right to, first and foremost, the issue of information. Information is key. It will move you from where you are to another level. That if I do not get this information even at home, then I don't think I'll get it from anywhere. So from our community perspective, we should change our attitudes towards women and people with disability, because it is only when we see them as full and whole people that we will then change the way we behave to women with disability, that even when they have choice of their sexual reproductive health or even their sexual desires, because there's a feeling that they're not sexually active, that probably they're not entitled to even have sex, they're not even entitled to have a husband, they're not even entitled to have a boyfriend, that perception then should change right from the community, that we should treat them differently, we should treat them like any other normal person, that they should be able to access the other services that are within our communities, be it education, be it health, be it whatever other services, that even when it comes to justice, and I do not know, even at police, because we're talking about health facilities, but when it comes to police also, that if there is a case that I'm reporting, my child has been raped, or she has gone through an assault, and maybe she has been abused, or she has been gone through a certain condition, that if I'm able to go to police and they say, you bring the person who has gone through this, is there anyone who can interpret? Is there anyone who will be sympathetic? Then, you know, there's that feeling of sympathy all the time, that, oh, please, what? No, I think we need to start treating women and people with disability as full people and people who deserve what we all get, and that if we change that attitude, then they will be able to access all the other services. Yeah. And when we come down to the health facilities and our own as government and other civil society organizations, I want to say that it should start from our own policies and our own documents that we have. How much of those do explicitly talk about the needs and priorities of women with disability? We say that we have left them out. That when we are making these documents, for example, the sexual reproductive health framework, which is was almost launched, and the policy which is revised time and again, women with disability may not explicitly surface within those vulnerable populations. Yeah, of course we know they are vulnerable populations, but how have they been catered for in those documents? That even when a health worker is giving a service, this is where she should be able to start. And that probably also the women with disability, they need to know much more about their rights, their sexual reproductive health and rights. That when I access the health facility, these are things that I should be going through, and that when I interface with a challenge, I should be able either to fend for myself, to speak about it, but also to report where I am not able to, so that it does not continue. Because one of the things we found out was that there is a resignation to the circumstances that women with disability go through, that there is an acceptance that probably this is the normal. This is what I should be going through, and that I should not be saying these things because after all, even at home, I'm treated this same way. So it comes from the documents that we have, and then investment by our own governments. That why should people, volunteers, why should other organizations think about adjustable beds? Making sure that, yeah, there's a policy, the 2006 Disability Act, that talks about making sure that the infrastructure is even within our own offices and wherever, that it is accessible to people with disability. But when you get to the health facilities, how much investment have we put in that? And when we put it there, have we consulted? Have we involved? Have we made sure that we are putting in the right things at that level? And then deliberately, if we are doing training of health workers, for me, I feel that there should be a deliberate effort to ensure that health workers are able to communicate with women with disability, that there must be a package in the training of a health worker, that right from the start I'm going to interface certain challenges within the, I mean, these are people that I'm going to interface with. I need to have certain skills on me, that I do not need to look at, wait for a relative to say something, because probably you are even impinging on the woman's confidentiality issues that she has to share with me, then she has to share with the person who is interpreting, and then, yeah, so how directly can I communicate with the person who comes in with disability? So infrastructure and investment. We know Ministry of Gender has done a lot, but probably the investment in sexual reproductive health is still lacking. That even within the funders who come in to fund our country, they need to look at it as a critical issue. That how much money is being assigned within our budgets to look at issues of sexual reproductive health for women with disability. Yeah, so because we can put up guidelines, we can put up policies, but if there's no funding and investment into it, it will still remain in the books. So I really feel that that is very, 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 very important. And I also want to add that for us as the international community of women living with HIV, having done this research, we found out that there are many vulnerable situations that are alike with us as different communities, but two vulnerable communities that we should, when we're doing our work, we need more, I would say, we need to work together on some of these things. That it is happening with women with disability, it is happening with women with living with HIV. Therefore, we need more collaboration, we need to have more movements on some of these issues that affect different populations, but they affect us all, even beyond HIV, beyond disability. That we should have more partnerships as organizations, and that we should be working closely together to ensure that some of these issues can be addressed either by our line ministries, but also by even the communities. Yeah.
And to you, Joy, what are your particular recommendations? Where do we need to see the change?
She has mentioned most of them. but I want also to supplement or add mine. When you look at the health sector, for example, when they are training health workers, I think in the curriculum they can include sign language so that the health workers know sign language. Because sometimes we have advocated and talked to them, like to the district health officer, but they would say we don't have money in the budget. Every time they talk about the budget. But if some health workers know sign language, if they are at the station, they can support women with hearing impairment. Or if the government has money, let them hire, advertise and employ, so that at every health center there is a sign language interpreter. When you go to court, there is no sign language interpreters. You find that cases are many there for deaf people, and sometimes they call organizations, would please help us with an interpreter, because they want to hear that case. That one takes long. But if they have one at the station, it would be something easy to handle the case, and there is access to justice for all. Then another thing, you find that when we are looking at access to information, let them change the way they perceive information. They give out information to people. I can give an example. The situation we are in today of COVID. You find that most deaf people, they don't know whether COVID is there or no, because they don't know. In the villages, you find them, if you tell him to wash your hands, I put on mask over what? He's saying people putting on masks. How masks for what? So if these people have information, they would also adopt what is going on. Then you find that the information sometimes mainly is put in one language. It is not translated in other languages. Like the media, for them they have now sign language interpretation, but it is done when they are at the news broadcasting. But in other programs, there are no sign language interpreters. You can bear with me.
But good thing is we have one here.
Right? Yes, I'm saying that not all.
Yes,
but sometimes you find that they miss out. Sometimes they complain. And when you say that you are putting information, you consider the visually impaired. They are those who use Braille. Do you have Braille information? So that these people who know how to read Braille, they can also read. So you find that government, most of the times they leave these things to NGOs. When they hear that there is an organization like deep on the world, they would say, let them handle issues of PWDs, which is not the case. Because we are all taxpayers. If we are paying taxes, we need also services to reach us. Access services for all. Not leaving out a section of people that because these are disabled people, let them go to organizations of persons with disabilities, which is not the case. So I want to appeal to the government. We are now in the process of budgeting. Let them involve us for the next financial year. Because when you look at the needs of persons with disabilities are alarming. For example, someone, if you want a wheelchair, it is between 700 to 1 million. Can a woman with disability at the grassroots afford? Even a caretaker cannot buy for you the wheelchair or tricycle. So it's better they budget for these assistive devices, which would support the mobility of persons with disabilities, also to perform effectively as others.
Well, as we have mentioned all the recommendations, as we wrap this up, I would like us to also speak to the woman with a disability, to remind her of her right, to remind her of what she can be able to actually access when it comes to SRHR, and how she can use her voice to speak out. So we'll start with you, Dorothy, and over to you, Joy.
Okay, so I want to appeal to women with disability that it is your right, it is your sexual reproductive health right, that you should be able to access, you should be able to make your decisions, sexual reproductive health decisions as a person, that if at all there are issues that arise, or if you meet any challenges along the way, then you should be able to speak out. Because unless if you speak out, then these issues are also able to be handled. And that we should not shy away when we meet some of these challenges, because when you speak out, probably you are speaking out for other women or young girls who are not able to speak out at that point in time. And that when we do access these services, we should always try as much as possible to get the comprehensive care and support. Because one of the things that we found out is that women with disability have very limited access. They do not even go anymore to the health facilities for the sexual reproductive health services. Very few go, that they have resigned and they are not going to those sexual reproductive health services. But in this era and time of COVID and also HIV, it is really paramount that we access these services, that they do cross each other's paths, but probably one will surpass the other. Access to information is paramount. So a woman with disability, it is your right to access the services, to access information, and that we should be able to speak out. We should be able to fend for our rights if we are being faced with any kind of challenge along the way.
Okay.
Yeah.
To you, Joy?
Thank you. I want also to appeal to fellow women with disabilities that the services are for all citizens. Wake up, rise and walk. Don't just sit at home and wait. Nobody will come for you to go for the services. These services are demand-driven, everything. The facilities are there for us, but sometimes lack of information, we can't access it all. So it's better we wake up as women with disabilities and seek for these services. And if the services are not so satisfying, it is better we have the leaders. The leaders are there. Inform them so that they can also step in for your support, so that we all live a happy life.
Yeah. I wanted to add something on the leadership, that representation actually comes right from the parliament, where we have members of parliament for the disability, right up to the grassroots level. So the leadership is there, but probably the issues that are being fronted do not include the sexual reproductive health and rights for women with disability. So we should be able to speak out on those, and we form that formidable voice around our rights as women with disability.
Well, I hope that the leaders are watching this. Our conversation this evening now, is all about access to sexual reproductive health rights for women living with disabilities in Uganda. To our panelists, thank you so much for joining us this evening. I was joined by Ms. Dorothy Namutamba, I beg your pardon, who is the Director of Programs and Advocacy at the International Community for Women Living with HIV, Eastern Africa. Next to her, Joy Nyakesa, who is the Programs Officer, SRHR, at the National Union of Women with Disability in Uganda. Thank you so much for joining us.
Thank you. Thank you for hosting us.
I hope from our conversation we will be forging a way forward that will help ladies living with disabilities be able to access these sexual reproductive health rights that they definitely have a right to access. I am Rita Kanya, and I was joined by Susan Mujawa on Sign Language. Have a good evening.